Good morning, everybody.
Morning.
I'm talking to you. Welcome to the 12th session of the CDC Public Health Ground. I'm Tanya Popovic, Scientific Director of the grounds, and I want to welcome all of you here in the audience and many, many, many more, hopefully, at our Envision sites and our external viewers. Today, it's all about the bones, and we are going to be focusing on the topic of vitamin D and how it's monitored in the United States. This is a topic that is a little bit different than some of the topics we have covered before, but I'm delighted to see many of you here interested in this, and I have actually had people from the infectious disease world call and say, are you going to be covering this or that? I actually had a couple of outside consultants unrelated to CDC call and say, do you need help? And I thought that the speakers and experts we have here can handle it, so I declined. I wanted to bring one thing to your attention, that as much as we believe that the work these days can be done only if 11,000 people publish something, there are very few papers where you have one or two people, and I think, again, the infectious disease world has the top role in that. This is one of the papers that Paul is going to be referring to, and I didn't even count the number of authors, but I would say it's probably upwards of 50. So just to document the enormous amount of interest in this topic in the scientific community. Reminder, this is getting to be boring, but sometimes I still get calls, can this be viewed on IPTV, and can I have my mother watch me if I'm sitting in the first row of the audience? Yes, we can be viewed through IPTV, and we can be viewed through external internet sites. So both external and internet sites. We are located at the director's webpage, internally and externally. And again, we are doing the Science Clips work in parallel with this, and so one of the features that we have done for the Science Clips in the last couple of weeks is selection of top 10 articles, and vitamin D issues made it, 2 of those articles made it to the top 10 this week. It's just a coincidence. Reminder that this is a continuing education session and that you can get CE credits either by participating directly live or viewing the session and then confirming that on the web later on. So our topics that are coming up are H1N1 influenza, alcohol, and malaria. Let me just say a couple of words about our speakers today. So as I said, this is a topic that is devoted to vitamin D and healthy bones, and some of you who may be familiar with this hilarious show may actually enjoy this hilarious group of people. Those are our speakers today, and they are Cliff Johnson, Christine Pfeiffer, and Paul Coates, and they are going to be covering the broad range of how do we monitor the issue, how do we monitor the population status, how we attack challenges when it comes to laboratory methods, and what does all the science tell us, so how we can actually put all these things in practice and implement policies. Let me ask you for just a couple of reminders. This is for the CDC audience. You may notice there are some orange and green notes, index notes in front of you. We would like, if you don't mind, for you to write just a sentence or two if you have attended more than 1 or 2 sessions. What are your general impressions? Even if you just say, I like it, I don't like it, what is it that you like or don't like? Please just write and then drop the card in the box outside of the auditorium so we can get some feedback. We are getting feedback via our web, but I also like to get the feedback from people in the audience. And the second reminder is that tomorrow is the deadline for the submission of the topics for the next round of the grand rounds, and I have received the number, but I wanted to remind you that tomorrow, close of business, is the time to submit your proposals. And with that, Dr. Frieden is unable to be with us today, but he has taped a few remarks, and if we can have his remarks now, please.
Welcome to Public Health Grand Rounds. Today's session is on the importance of vitamin D. Vitamin D supplementation reduces osteoporosis. But what is the evidence for additional health benefits? Many questions remain about vitamin D. How effective is it, if at all, in reducing cancer, diabetes, and heart disease? How much is safe to take? How can we improve the measurement of vitamin D status? What can we do about the inverse care law, whereby those who need the most get the least and vice versa, in vitamin D sufficiency? These questions have led to a new review of vitamin D dietary reference intakes by the Institute of Medicine. We anticipate that review will be released in the coming month or two, and today's Grand Rounds provides the latest evidence of vitamin D effectiveness and safety and explores the challenges we face measuring and defining vitamin D status. Thank you.
Thank you, Dr. Frieden. And Cliff, the floor is yours.
Good morning. My name is Cliff Johnson. I'm the director of the Division of Health and Nutrition Examination Surveys at the National Center for Health Statistics. Vitamin D is one of the most talked about nutritional issues in the U.S. today. Vitamin D is also an issue globally. In this presentation, I will discuss what vitamin D is and why we need it, what scientific and public health issues have made it such a talked about issue, and how vitamin D status in the U.S. population is evaluated through the NHANES survey. I'll also discuss some challenges in assessing vitamin D status and ways to address them. Vitamin D is a fat-soluble vitamin that helps the body absorb calcium. It is needed for bone growth and bone remodeling. Vitamin D has other roles in human health, including modulation of neuromuscular and immune function and reduction of inflammation. The human requirement for vitamin D can be met by exposure to sunlight and through diet and supplements. Most people meet their vitamin D requirements through exposure to sunlight. People who avoid the sun, who cover their bodies with sunscreen or clothing, or who live in northern climates would likely need good sources of vitamin D in the diet or to take a supplement. Very few foods in nature contain vitamin D. Primary sources include fortified milk, some yogurts, some fortified cereals and fruit juices, and the flesh of various fatty fish. Vitamin D is also available in vitamin and mineral supplements. Vitamin D that comes from foods, supplements, and the sun is biologically inert. It is rapidly taken up and transported to the liver and converted to the circulating form of 25-hydroxy vitamin D, then to the active form 1,25-dihydroxy vitamin D in the kidney. The production of 1,25-dihydroxy vitamin D is tightly regulated by parathyroid hormone. A number of population groups are at higher risk of vitamin D deficiency. They include breastfed infants, older adults, people with limited sun exposure, people with dark skin, people with fat malabsorption, people who are obese, or people who have undergone gastric bypass surgery. These groups are at increased risk because of higher physiological requirements, diets limited in vitamin D, or other environmental factors such as limited sun exposure. Low levels of vitamin D, less than 27.5 nanomoles per liter, have been shown to be associated with a high risk for rickets in children. With fortification of milk with vitamin D, cases are extremely rare. In adults, inadequate levels of vitamin D leads to osteomalacia, causing bone pain and muscle weakness, and possibly fractures, especially in the elderly population. In recent years, low vitamin D levels have been associated with increased risk for numerous other health outcomes, including various cancers, cardiovascular disease, autoimmune disease, dementia, diabetes, and glucose intolerance. These associations are primarily based on ecologic or observational studies. The cause and effect has not been proven for most of these associations. At the same time, excessive amounts of vitamin D in blood can become toxic and can produce a variety of health problems. So excess as well as deficiency is important with respect to vitamin D. What is clear today is that vitamin D is of great interest not only to the public health research community, but to the general population and the media. This slide shows just a few examples of press headlines in the past 2 years related to vitamin D and its reported relationship to many public health diseases and conditions. Others in the research community encourage caution relative to the merits of vitamin D and various disease endpoints. For example, the Journal of Epidemiology editorial shown on this slide expresses concern that vitamin D may just be the latest in a long list of nutrients linked to various forms of cancer, all of which were eventually shown in randomized clinical trials to be shown not to be the panacea for most forms of cancer. Thus, at this time, there is no general consensus with respect to vitamin D and various health outcomes. We have an obvious need to know what the vitamin D status of the U.S. population is and whether it's changed over time. It is also important to know how much diet is contributing to vitamin D status and what foods are providing the most vitamin D for the population, as well as if dietary supplements provide a significant amount of vitamin D to the population who are taking them. Finally, the scientific and public policy community, as well as the public, need to know how much vitamin D do we need, how much is too much. A number of sources of information provide valuable data to inform the research and public health policy community in their ongoing discussion of the importance of vitamin D and health outcomes. They include clinical research studies, randomized clinical trials, and population-based surveys or surveillance systems. Public health policy and intervention programs use all of these sources of information. One critical set of information needed is the status of the population now and in the past. The National Health and Nutrition Examination Survey, or NHANES, whose primary objective is to assess the health and nutritional status of adults and children in the United States, is the most significant population-based survey that provides data to inform the scientific and public health community on a variety of nutrition and public health topics, including vitamin D. NHANES has been unique and a critical source of data on nutrition and health for the past 50 years. First as a more targeted survey in the 1960s, and then as a periodically conducted survey of health and nutrition from the early 1970s through the mid-1990s. Beginning in 1999, the survey became continuous, and NHANES is continuously conducted as 2-year cycles covering the entire age range of the U.S. non-institutionalized population. NHANES provides critical data and international standards for many essential public health functions. A few examples include weight and height charts, dietary intake, diagnosed and undiagnosed diabetes, folate levels before and after fortification, lead levels in children, and population exposure to secondhand smoke before and after smoking regulations. This survey has and continues to be responsive and relevant to current and future public health data needs. Assessing the U.S. population's vitamin D status and monitoring that status over time has been a focus in the NHANES survey for the last 2 decades. Vitamin D status can be evaluated using either vitamin D intake data from foods and supplements or from looking at vitamin D in serum. Collecting risk factor data previously associated with vitamin D status is also part of the survey, but will not be discussed as part of this presentation. I will first focus on vitamin E from intakes in foods and supplements. With respect to vitamin D intake from foods and supplements, the primary questions are, is intake adequate, and what are the groups of concern? The Institute of Medicine Dietary Reference Intakes Report from 1997 defined adequate intake of vitamin D as 200 international units per day for those less than or equal to 50 years of age, 400 international units per day for those 51 to 70, and 600 international units for those 71 years of age or older. They also define pregnant and lactating females. Guideline for adequate intake is 200 international units per day. In addition, they also defined a tolerable upper level intake for all population groups of 2,000 international units per day. Based on an analysis of recent dietary intake data from NHANES, both foods alone and foods with supplements, much of the U.S. population is not meeting the recommended adequate intake for vitamin D. This is especially the case for men over the age of 50 years. In those age groups, only 1/4 to 1/3 meet the recommended adequate intake. And for those oldest age groups, dietary supplements are a significant source of vitamin D intake. For females, the pattern of total intake is similar to that for males, with the exception of the 14 to 18-year-old girls. Fewer than 1/3 of the 14 to 18-year-old girls and the women 71 years of age and older have adequate intake. For females ages 14 and older, dietary supplements contribute significantly to the total vitamin D intake. I will next focus on levels of vitamin D in serum. Serum concentration of 25-hydroxy-vitamin D is generally accepted as the best indicator of vitamin D status in blood. A radioimmunoassay method was used to assess 25-hydroxy-vitamin D in NHANES 3 as well as in the continuous HANES through the N2005-2006 cycle. However, there was a reformulation of the RIA method after HANES 3 and before the start of the continuous survey, with the consequence that we need to bridge the gap between the data obtained by the different RIA methodologies. In the following presentation, Dr. Pfeiffer will address the complications that occur because of assay method changes and the resulting implications for interpreting trends in findings over time. There is also disagreement among experts in the most appropriate cut point for optimal health for 25-hydroxy-D. Since the release of the IOM report in 1997, the cut point of less than 27.5 nanomoles per liter has been used in the country to define deficiency status for vitamin D. This cut point was known to be associated with increased risk for rickets and osteomalacia. In recent years, other cut points, such as 50 and 80 nanomoles per liter, have been proposed by members of the research community as more appropriate cut points for inadequate or at-risk status, especially for other public health concerns and diseases. If these three proposed cut points for vitamin D inadequacy or deficiency are applied to the NHANES data, you will come to very different conclusions about the vitamin D status of the U.S. population. At 27.5 nanomoles per liter, shown in light green, the prevalence for all population groups is less than 6%. At the cut point of 80 nanomoles per liter, shown in light purple, one concludes that more than 70% of the population has inadequate vitamin D levels. The cut point of 50 nanomoles per liter, shown in dark purple, and as expected, produces a prevalence of vitamin D inadequacy about 30% for the population. Differences among race ethnic groups in the prevalence of low levels in serum 25-hydroxy-D have also been found, but the meaning of this is unclear at this time. NHANES is a valuable source of information on vitamin D. Based on the current IOM criteria, for intake, fewer than 1/3 of older people meet the recommended adequate intake for vitamin D based on total intake, that is, including supplements as well as foods. Somewhat differently, when you look at serum levels, fewer than 6% of the U.S. population has 25-hydroxy-D levels below the value generally considered inadequate. An additional analysis of HANES 3 and continuous HANES data have shown that biomarker serum levels decreased slightly from the 80s and 90s to now, most likely as a response to altered behavior, such as the fact that there's increases in body mass index, likely decreases in sun exposure, and in milk consumption. A number of interpretation and methodologic issues provide both challenges and opportunities. There are two ways to assess vitamin D intake in the U.S. population, as I mentioned, intake and blood levels. Measuring each have methodological challenges. The correlation of serum levels with adequacy is only established at 27.5 nanomoles per liter for children. Reformulations or changes in laboratory methods complicate the interpretation of trends and status over time. And there's no generally agreed upon cut point for vitamin D, either deficiency or adequacy. Thus, all issues that may lead to a misinterpretation of population levels have to be examined carefully and communicated promptly. The Institute of Medicine is currently reviewing the recommendations for intake of vitamin D, as you heard from Tanya, along with calcium. Their charge is to assess current relevant data and to update, as appropriate, the dietary reference intakes for vitamin D and calcium. Specifically, the IOM will review evidence on indicators of adequacy and indicators of adverse effects from excess, give priority to indicators of adequacy for the various age, gender, and life stage groups to define an estimated average requirement, or EAR, give priority to selecting a critical adverse effect to define a so-called benchmark intake, and to identify research gaps to address the uncertainties identified in the process of deriving the reference values and evaluating their public health implications. The IOM report is well underway, and it's expected to be this report on dietary reference intakes, or an updated report for vitamin D and calcium, is expected to be completed in the late fall of 2010. Depending on the recommendations and possibly new cut points, further analysis of the NHANES data on vitamin D will likely occur, and future programmatic directions and public health guidance for vitamin D will likely be determined. I would now like to introduce Dr. Christine Pfeiffer.
Good morning. I'm Christine Pfeiffer from NCEH. I will focus on methodological challenges that have prevented us in the past from having precise measurements of vitamin D status in the U.S. population, and will tell you about what we are doing to resolve that. As you heard from Cliff Johnson, serum samples have been collected via the NHANES survey since 1988. They have used a sensitive radioimmunoassay, RIA, developed in the mid-1980s to measure total 25-hydroxyvitamin D. Immunoassays cannot distinguish between the D3 and the D2 forms of 25-hydroxyvitamin D, and therefore measure the total amount. The original diazorin RIA was used during NHANES 3, then the manufacturer improved the assay imprecision, and its precision consequentially, and their reformulated assay was used during 2000 to 2006. Due to some shortcomings of the immunoassay methodology, CDC decided, after obtaining input from a roundtable of experts, that the liquid chromatography coupled to tandem mass spectrometry, LC-MS-MS, should be used for NHANES 2007 forward. This assay measures the individual 25-hydroxyvitamin D forms. Several undesirable performance characteristics make the classical immunoassay methodology less suited for long-term monitoring of population trends. First, the imprecision of the diazorin RIA was quite high, with a coefficient of variation of 10 to 20%, which made monitoring small changes in the population over time difficult. Second, immunoassays are less specific than chemistry-based methods such as LC-MS-MS, meaning that compounds other than 25-hydroxy-D may alter testing results. And lastly, the diazorin RIA is less robust than desirable, meaning there are fluctuations in assay performance over time. All these issues made interpretation of changes in the population over time more difficult. Specifically, the change from the original to the reformulated assay produced 25-hydroxy-D results that were on average 12% lower, which you see in this cartoon. Furthermore, our laboratory observed that the reformulated RIA fluctuated over time. Between 2000 and 2006, the assay performed for some extended periods, sometimes 5 to 10% higher, sometimes lower than expected. Obviously, this had an impact on monitoring of population levels, and I will show you this on the next slide. These data are from a publication led by Dr. Enlucker from NCHS. In panel A, you can see that the observed age-standardized means were 10 to 18 nanomoles per liter higher in NHANES 3, the light blue bars, where the original diazorin RIA was used, than in NHANES 2003-4, the dark blue bars, where the reformulated assay was used. Panel B shows that when NHANES 3 values were adjusted for the change in assay, the difference in age-standardized means between surveys was reduced by 10 to 11 nanomoles per liter, depending on sex. This means that a large proportion of the previous difference between these two surveys was attributable to changes from the original to the reformulated assay and not to the real difference in population levels of vitamin D. Just a few months after the Looker paper was published, prior to having the wider scientific community made aware of the importance of adjusting the data, another group, Gindi et al., published data from the same NHANES set. They arrived at the conclusion that the prevalence of serum 25-hydroxy-D levels lower than 25 nanomoles per liter more than doubled between NHANES 3 and 2001 to 2004. This estimate, however, is inflated because they didn't adjust the NHANES 3 data for method differences. These two examples, the Looker and the Ginde paper, highlight a couple of important points. Rather small changes in 25-hydroxy-D levels as a result of assay changes can lead to big changes in population levels. Lack of data adjustment for assay differences can lead to very different conclusions. And timely and appropriate communication to the scientific community is critical to avoid having incorrect messages being published. Now let me give you an outlook to the new analytical methodology we are adopting for NHANES, LC-MS-MS. Compared to the diazorin RIA, this method has improved precision, much higher specificity, and because it is calibrated in-house with certified standards and verified regularly with NIST reference materials, its robustness, or the reproducibility over time, can be more easily maintained. But if we're changing methods, how do we make the past and future data comparable? Last summer, the NIH Office of Dietary Supplements and the CDC NCHS sponsored a roundtable on vitamin D issues in NHANES. The experts agreed that the future methodology in NHANES should be the LC-MS-MS method. They recommended that a subset of samples previously analyzed with the diazorin RIA be reanalyzed with the LC-MS-MS method to bridge the past and the future. Most importantly, though, the experts agreed that data generated previously with the diazorin RIA need to be adjusted for assay changes to avoid incorrect interpretation of the trends. After a long development and validation phase in which our laboratory closely collaborated with the National Institute of Standards and Technology, last summer, NIST released the first standard reference materials for 25-hydroxy-D. These materials are expected to improve the accuracy of measurements and the comparability of data across methods and laboratories. The question remains as to whether these materials are also suitable to calibrate immunoassays. This has to be investigated in a commutability study, which is currently being planned by NIST and CDC. So what are the lessons learned from this excursion into the world of analytical methodologies that will help us move forward? Relatively small assay fluctuations can have a large impact on population levels and make interpretation of population data difficult. The best possible analytical methodologies are needed for NHANES to ensure that small changes in the population can be detected unequivocally. While often hard to sell, the standardization, harmonization, and accuracy of analytical methodologies used in NHANES should be supported and strengthened. The validation of our new LC-MS-MS method is currently underway, and so is the bridging study for samples analyzed by different methods. These will be critical steps to a better interpretation of trends of 25-hydroxy-D levels in the US population. Thank you, and our next speaker will be Dr. Paul Coates.
Good Good morning. I'm Paul Coates. I direct the NIH Office of Dietary Supplements, and I thought that by way of introduction I'd tell you where we came from. The Dietary Supplement Health and Education Act of 1994 authorized the establishment of the office, ODS, at the National Institutes of Health. Our mission is to strengthen knowledge and understanding of dietary supplements to foster an enhanced quality of life and health for the U.S. population. In doing that, we evaluate scientific information, we stimulate and support research, we disseminate the results of that research, and the ultimate goal is to educate the U.S. public. What I wanted to do today was to tell you about our role in this. We've had a long interest in vitamin D as it's become recognized as a potentially important public health intervention. We've learned from Cliff Johnson's talk that vitamin D has assumed considerable status in discussions about risk for serious health conditions. There's clamor for more vitamin D intake, more and more call for people to have their vitamin D status monitored and measured. They're not unreasonable goals, but we need to look more closely at the evidence for these relationships before we as the government make stronger recommendations about vitamin D for the general population. I'll try to address some of the scientific issues that are now being actively pursued, as well as some of the key players who are involved. I wanted to tell you about an initiative called the Vitamin D Initiative that coordinated out of the Office of Dietary Supplements, but way more important than that, it involves partners from other DHHS agencies, including, in addition to NIH, CDC, FDA, and the Agency for Healthcare Research and Quality, along with the National Institute of Standards and Technology, the Department of Defense, the U.S. Department of Agriculture, and related agencies in Health Canada. The goals of this partnership are to improve the measurement of vitamin D in foods and in dietary supplements, to improve the measurement of vitamin D status in NHANES and in other surveys, as well as to identify and fill research gaps. To date, the outcomes have included a series of systematic reviews of the relevant literature, publications of the recommendations of vitamin D status measurement in NHANES, and a publication of a report of research communications emanating from a roundtable that we held at the NIH in 2007. All of this, we hope, will inform public policy. As you're aware, there is considerable information about vitamin D in the literature, but there's also an awful lot of opinion, sometimes based on a selective reading of that literature. We've adopted a systematic review of approach to addressing the relevant literature on vitamin D and chronic disease conditions. We've done this in collaboration with our sister agency, AHRQ, which operates a network of evidence-based practice centers around the U.S. and Canada to address challenging health conditions. The reviews are often used to inform public policy, to develop clinical guidelines, to inform insurance coverage decisions, and in our case, to build research agendas. In recent years, ODS, along with other partners in the U.S. and Canada, have sponsored 2 systematic reviews of vitamin D, and I give the references to those here. The first systematic review was conducted by the University of Ottawa's Evidence-Based Practice Center, and it focused on bone-related issues. At that time, it was clear that most of the data were available for bone-related concerns. But even in this case, apart from a strong body of data relating vitamin D supplementation to improve measures of bone health in the elderly, there were considerable gaps in available knowledge for other population groups. Furthermore, it was noted, appropriately, that the effect of vitamin D could not be separated from that of calcium, since most studies included a calcium supplement along with vitamin D. And finally, it was not possible to say at what level of vitamin D status, measured by serum 25-hydroxyvitamin D, what level could predict the risk of bone-related injury, at least in adults. The second review, which was conducted by Tufts University's Evidence-Based Practice Center, extended the discussion to the role of vitamin D in other health conditions and included a review of calcium and health as well. This review was specifically commissioned by the governments of the U.S. and Canada to inform the upcoming evaluation of the dietary reference intakes for these nutrients by the independent DRI panel that Cliff referred to earlier. Briefly summarized here, an extensive array of data looking at the cause and effect question that most of us are interested in. And it summarizes a lot of data here suggesting that there is little effect documented to date in most of those studies. I don't think we should take the message away that this means there is no effect. It simply calls on us to look critically at the paucity of data that's currently available and expand the discussion to include additional studies. The IOM review, as Cliff noted, is underway and is expected to report out towards the in 3 or 4 months or so. I think a little later than Dr. Frieden suggested. New data. The challenges associated with this are developing a better understanding of the relationship between exposure and effect. Very likely, a cause of uncertainty in many previous studies is the difficulty in actually measuring the exposure to vitamin D. As Cliff noted, an important advance has been made with the ability to now measure vitamin D exposure from all dietary sources, including dietary supplements and food sources. But we still have challenges in measuring the proportion that comes from sun exposure. In general, while many observational studies have pointed to a strong relationship between vitamin D and health outcomes, there have been inconsistent findings from control trials, as shown from the systematic reviews. And finally, as noted by Dr. Pfeiffer, problems in the measurement of vitamin D status and a failure to understand those problems may have led to incorrect interpretation of vitamin D status, especially in assessing trends over time. Let me give you one example that we've been confronted with. There are clues from ecologic studies, such as the one presented here, that point to a benefit of vitamin D here in reducing the risk of colorectal cancer. This is an ecological study that ends up with a summary statistic at the bottom, the diamond suggesting that there's an improvement, an odds ratio of about 0.7 when one compares high versus low circulating levels of 25-hydroxyvitamin D. And this has been documented for several other conditions as well. There have been very, very few clinical intervention studies related to cancer. But the results of one of them are shown here. In this study that was published in 2007, older white women in Nebraska were followed for 4 years in a 3-armed randomized controlled trial of vitamin D and calcium. And the incidence of all cancers after 4 years was scored. A substantial reduction occurred in the frequency of cancers in the calcium-only arm, the red line, compared to placebo, and a further reduction was seen in the group to which vitamin D was added, leading to a rather impressive statistical analysis. The limitations of this study, though, included a couple of things. One is cancer incidence was a secondary outcome, and no vitamin D arm was included in this study. However, the National Cancer Institute, which funded this study in the first place, has recently funded the same group to conduct a follow-up study similarly designed but with additional arms, the results of which will be available in a few years. I wanted to tell you briefly about the Women's Health Initiative, an NIH-sponsored study that was the largest interventional study in history. It recruited 160,000 postmenopausal women to a variety of studies over a 12-year period of time, 15-year period of time. Here was an opportunity to examine the long-term effect of calcium and vitamin D supplementation in a subgroup of women who were studied for 7 years to examine the potential effects on hip fractures. The results of this long-term study, the huge number of authors indicated in the first slide that Tanya showed, no significant effect on fractures occurred. There was a 12% decrease across the population, but it was not significant. The fracture rate did decrease significantly among women who complied with supplement use, an important finding. Of note, however, the last bullet here is that there was a statistically significant increase in kidney stones in the women who were on vitamin D and calcium. This finding, I have to tell you, has been rarely reported elsewhere, but it certainly needs to be followed up. And that's particularly the case as the result of this study, which for me points out yet another value of NHANES, the ability to be able to correlate data from very different kinds and examine trends and use them as clues for the development of future studies. Here, all-cause mortality was plotted as a function of 25-hydroxy vitamin D level in NHANES 3, so this is 1998 to 1994. And then individuals were passively followed for mortality through 2000. As expected, the lowest quartile of 25-hydroxy vitamin D level on the left, which corresponded to about 18 nanograms per mil, was significantly associated with increased all-cause mortality. Still, a non-significant increase in mortality, largely due to cardiovascular and cancer-related deaths, occurred at the highest levels of vitamin D. In other words, a U-shaped curve. I don't want to overinterpret this, but because those data were not significant at the high end, and it is clear from the confidence limits that data are scant at the right-hand end, but the finding remains unexplained. We need to understand the biology of this finding, especially if we're going to recommend increases in vitamin D and therefore shift the entire population to the right. I did want to give you some idea of ongoing research that's funded by the NIH, and it's not NIH-centric, it's just what I know best. The several institutes and centers and offices at the NIH are now funding the VITAL trial. This is vitamin D and omega-3 fatty acid trial to examine the role of vitamin D and omega-3 fatty acids in the primary prevention of cancer and cardiovascular disease. The National Institute on Aging and others are funding a dose-response study for vitamin D in the elderly, incidentally the kind of data that are much needed to inform dietary reference intakes kinds of discussions. The NCI, as I noted, is funding the replication of the cancer incidence study that provided provocative and possibly useful findings. Many institutes and centers at the NIH are engaged in funding of intermediary metabolism studies that will help us to understand better the biology and metabolic fate of vitamin D. And finally, ODS, along with CDC and NIST, have joined forces to develop important analytical tools for the measurement of vitamin D status, including the reference material and reference methods that Dr. Pfeiffer referred to. Finally, I wanted to give you a summary of the current recommendations that relate to vitamin D intake. You've seen the numbers from Cliff before. Adequate intake levels were judged in the 1997 report to be incremental, 200 in the young, 400 in intermediate age, and then in 70 and above, 600 international units per day, with a tolerable upper limit for all ages above 1 year of 2,000 international units a day. Well, how do people meet these recommendations? It's generally suggested that people can engage in some brief sun exposure, although there is no agreement among organizations about that. Neither is there much agreement about how much sun exposure would meet that need. It's a very complicated kind of question, as we've come to learn. Foods, especially those fortified with vitamin D, remain a source of this important vitamin, but it turns out that, as Cliff's data showed, that in some populations, particularly among the elderly, supplements are required. While we're waiting for the results of the ongoing review by the Institute of Medicine, other organizations have made recommendations. I've selected some here. They're by no means the only ones. But the pediatric organizations of the United States and Canada have recommended increased levels of intake over those recommended by the IOM. The American Academy of Dermatology recommends more from supplements and not more from sun exposure. And in general, these organizations have also recommended target values for 25-hydroxy vitamin D. And while we think that the approach has some merit, we're less certain about the actual target values and remain very excited about the possibility of learning more from the IOM report. So, in closing then, and this kind of summarizes a lot of what the three of us have said, we need the following. We do need to continue monitoring the status of vitamin D in the population, especially if there's going to be any public health recommendation that might change those the recommended intakes. We need more data on dose-response relationships. We certainly need more data on basic research mechanisms. And a lot of this will be driven by the existing and we hope ongoing partnerships that occur among agencies in the United States and Canada, including the CDC, the NIH, NIST, USDA, and others, including Health Canada. So thank you very much on behalf of all of us. Let me turn it back over to Cliff, who will moderate the next part of the session.
Thank you, Paul. We have approximately 15 minutes for questions, so if anyone has questions, there are microphones in the middle on each side, and that would be the preferred approach if you would like to come and ask a question. Go, Tom.
I'll ask a question. Tom Sinks, National Center for Environmental Health. I'm trying to get the takeaway message from the presentation, and I may have it wrong, but it seems to me the takeaway message is we're concerned about vitamin D insufficiency across the population, particularly in certain subgroups. But then when I look at the health effects, it's not clear to me that we're actually experiencing changes in increased prevalence of rickets or osteoporosis that I believe the major IOM recommendations are set to prevent. And so one question is, okay, we're insufficient, but how much of a public health problem do we really have? The second question is, I wonder if you can address the issues of cancer prevention, and if the intake recommended for cancer prevention is actually within the same range of exposure, or is it significantly higher than that recommended to prevent osteoporosis and rickets?
The data that are being used to summarize these relationships are not strong. They're not always of the highest value, and they don't always cover all of the questions that probably really need asking. Given that there's uncertainty, there's an opportunity for people to take fairly strong stands on the basis of the available information. There is a public health issue here. How strong it is remains unclear. People are not experiencing, to my knowledge, the kinds of increases in osteoporosis that might be attributable to shifts in status. People are not experiencing the shifts in cancer incidence that might be associated with the shifts, partly because we're not certain that the shifts have actually taken place. I think the data that Christine and Cliff both showed suggests that while some have concerns about a markedly downward slide in the vitamin D status of the population, we're not so certain that that's true. Given that most of the data are ecologic, we do have to understand that they are confounded by a number of other things. I'm not saying that there isn't going to be a relationship. The fact is that at this stage, I don't know if there's a relationship, and I'm anxious to see it played out.
Bill?
Bill Dietz, Division of Nutrition, Physical Activity, and Obesity. Part of the problem that I think you've nicely articulated is the lack of a criterion-based standard for vitamin D deficiency. And you alluded to population-level outcomes, cancer, osteoporosis, mortality. And I wonder if you could comment on which of those areas you think is most likely to produce a criterion-based standard, or whether there are some other functional tests like the vitamin D, an in vitro assay that might help us understand what level of vitamin D is most appropriate for bone growth.
I'm happy to try, Bill. This is a difficult question, and it relates to some of the things that are on this slide that I forgot to turn off. But dose-response relationships remain a serious lack in these discussions. And we don't have models for being able to explore those. It takes a long time to do the kinds of dose-response relationships in humans for chronic disease issues. And we probably need to develop or work with other kinds of study designs, including experimental models, at least to give us some clues. The only really the only real certainty that we have is that 27.5 nanomoles per liter number is associated with an increased risk of visible disease. And it doesn't mean that everybody below has that disease and everybody above does not, but it has been recognized for quite a while that that's a clear relationship. Beyond that, it becomes very difficult because of the things that we lack. And I welcome any ideas in trying to decide how could we move forward better. Understanding the basic mechanisms and so on would be valuable.
I'm Jim Bueller from the Public Health Surveillance Program Office. I had two questions. Other than the bone effects, can you speak to the biologic plausibility or the biologic pathways that vitamin D may be having an effect on some of the other conditions that you addressed? And then secondly, are there, I realize the focus of this talk was primarily on the United States, but as a global health issue and in settings where nutritional deficiencies are more severe and prevalent, are there any unique aspects of the issue of vitamin D deficiency as a public health concern?
I'm happy to try that one too. You ask all the easy questions, and I appreciate the chance to be able to answer them. The clues that we get about the biologic plausibility of the role of vitamin D in predisposing to other conditions beyond bone have to do with some very important observations. One is that vitamin D receptors are present on a universe of tissues, not just bone. And so that provides a clue. That's all it does unless you then take some of the next steps. Vitamin D, of course, is a hormone as well as being an essential nutrient, and that complicates some of these questions. If you start to think about it as a hormone and then it having further effects, some of those are under active discussion at the moment. Does it act as an anti-inflammatory, or does it promote anti-inflammatory kinds of responses? Is a possibility. There are clues there. But at the moment, I think we are jumping a little bit from what we see in observational studies and making a leap or two. Maybe it's appropriate, maybe it's time, but I'm a geneticist by training and a lab rat by training, and I like to be able to take an observation and take it 2 or 3 more steps to explore the mechanism before I'm prepared to really conclude that there is more than just a relationship here. In terms of the global aspects, this is clearly an area where we have to get a better handle. There are various estimates that suggest that the global burden of vitamin D deficiency, and that's a term of art, could be as many as 1 billion around the world. But what is the number that's being used to define that? It's probably not 27.5. It's probably a number that's considerably higher than that.
Before we take another question from the audience, I would like to know if there's any questions from Envision real quickly. Okay, hearing none. Over here on the left.
Brooke Steele, Division of Cancer Prevention and Control. A number of healthcare providers are testing their patients. Are there questions that the patient should be asking of the providers?
Another, may I? I'm pleased to try because this is something that we think about all the time. Ours is an Office of Dietary Supplements. Dietary supplements are intended as a public health kind of intervention, as a risk reducer, not a disease treater. And of course, it doesn't matter what our office focuses on. The fact is that vitamin D questions are being asked in the public health environment as well as in the medical management environment. There are a couple of things. I just learned, for example, a couple of days ago that in Canada, the Ontario Health Assessment Technology Council or Advisory Group has made a recommendation to the Ontario Ministry of Health that they stop paying for the routine measurement of 25-hydroxyvitamin D status in the otherwise unaffected population. There are circumstances where, of course, it's necessary. But this comes hard on the heels of there being very active and enthusiastic commitment to the measurement in everybody and often to monitor and track your status. Because I don't know what to tell people about I don't know what number to tell people to shoot for. Oh, and I don't know that that number is reliably measured. It may be, but I don't know that. I have difficulty in being able to make a very specific recommendation at this point. I think the advances that have been made by Christine's laboratory, along with NIST, in harmonizing the measurement of 25-hydroxyvitamin D, this will go a long way to giving us the basic tool. Then the question becomes the one that Bill asked earlier, and that's how do you know when you've reached a level that's relevant? So I'm sorry that, at least from my point of view, I don't have a direct recommendation to make.
I think we might have time for two more questions if they're short on this side on the right.
I have a comment and a question. I started my career as a pediatrician, and vitamin D and rickets prevention was a huge topic. And at that time, we didn't have the luxury of measuring vitamin D levels. We used the calcium to phosphate ratio and the level of alkaline phosphatase. My question is, and these did change with vitamin D treatment. So my question is anybody attempting to look at simpler lab measures that reflect vitamin D metabolism? And the other question is, since parathyroid hormone levels are inversely associated with vitamin D levels, are these looked at NHANES? And what is their sensitivity and specificity if the two measures are combined?
Yes, a short answer. For us, for NHANES, we're only measuring the direct indicator because it's really the best indicator to assess status, and so we're not looking at other indicators to assess the vitamin D.
Are they available if people want to look at them?
Oh yeah, vitamin D assays are available throughout clinical as well as other measures.
My question is calcium levels and phosphate levels, are they available?
Those assays are also available, and some of the biochemistry profile of NHANES has those values as well.
Yeah, some of those have been measured in various NHANES surveys, so not all the time, and in our standard biochemistry profiles, some of those are there as well. So, but that's probably a good question we can talk with you about after the session is over, because there are a lot of subtle parts to that we go into. And I think in the essence of time, let's try and get the last question, but we'll be happy to talk with you afterwards.
Yeah,
Yes.
Camille Barbour, Division of Adult and Community Health. Michael Hollick's New England Journal of Medicine paper mentions vitamin D sufficiency at around 30 nanograms per mil, and it's mostly based upon the parathyroid levels. But in my research, I've been finding it to be around 20 nanograms per mil using LCMS and using various cohorts, WHI, osteoporotic fractures in men study. I was wondering, what are your thoughts on this?
This is an area of active interest in our own group. Chris Sempos, who is a population scientist in our group, has recently published some data in collaboration with Bess Dawson Hughes using her study and addressing this issue about PTH suppression is a good measure of maybe when you have full adequacy of vitamin D. And the number is under some discussion. It depends on what you look at. So he's trying to, at this point, do some modeling to determine whether there are ways in which you can look at this relationship in more detail. But I think, in general, the number that you suggest, 20 nanograms per mil, which is about 50 nanomoles per liter, is the one that has been used for that purpose.
So I think with the questions you can see before I turn it back over to Tanya, we're still in a state of lots of questions to be answered. We're all anxiously awaiting the IOM report, and I doubt the discussion will end after that report comes out.
Thank you all very much. And I'd like to point out that every time in these sessions I find myself educated on the topic and then on something special. So today I learned from Paul that I'm not a senior citizen, that I fall into the intermediary category, and I actually like it much better than being a senior citizen. So I thank our speakers, thank you, the audience here and outside of CDC, and invite you to join us in 4 weeks again. Thank you.